Hello and welcome. I am Denai Wells, the GPS Marketing Product Manager at MDX Health. As you guys all know, prostate cancer decisions are not one size fits all. Two men with the same risk score can face very different futures. Exactly what we're going to talk about in tonight's webinar. We'll explore how patients' tumor biology and their clinical risk assessment work together to help inform shared decision making for you and your patients. To lead us through, I'd like to introduce tonight's author and keynote speaker, Dr. Marcio Moscovas. He is a urologist, a robotics surgeon, and research coordinator at Advent Health Global Robotics Institute. He brings extensive expertise in telesurgery across multiple international platforms, and he holds a PhD in robotic surgery and has authored over 150 scientific publications. Earlier this year, in European Urology Oncology, Dr. Moscovas and his colleagues published Integrating Genomic Prostate Score with Preoperative and Postoperative Cancer of the Prostate Risk Assessment Scores, or CAPRA, to predict biochemical recurrence after radical prostatectomy. This is the work at the heart of tonight's discussion. If you do have any questions during the presentation, please do submit them through the Q&A feature. They will be saved and answered during the panel discussion at the end. And to make things a little bit easier today, we did pre-record the publication overview, but when that concludes, Dr. Moscovas will formally introduce our other panel members tonight who will share their cross-institutional perspectives this evening. All right, without further ado, let's get started.
So hello, everybody. I'm Dr. Marcio Moscovas. I'm a urologist, uro-oncologist here in Celebration, Florida. And it's a great pleasure for the invitation. Thanks for inviting me. And I'm going to talk a little bit today of our recent work in European urology, our recent publication here, talking a little bit about the GPS, the association of the GPS with the CAPRA score, basically to predict biochemical recurrence. But I'm going to talk a little bit more details about our main endpoints of this study. This is a nice study. It's an open access. So if you guys are interested, you just take a look over there. You're going to see this work a little bit deeper. And the main idea of the study was to associate the GPS score, the genetic score, with the CAPRA and the CAPRA-G, the CAPRA preoperative CAPRA and the postoperative CAPRA score. I'm going to talk a little bit about this about the CAPRA as well. So that's the main goal that we have. First, starting with CAPRA is a very known tool here, validated tool, basically to estimate the risk of biochemical recurrence after radical prostatectomy. And this is a nice tool. If you guys don't use it, I recommend it to start using. It's very well known in all recent publications, especially, and it associates some scores, associates scores with the PSA, Gleason score, clinical T stage, percentage of positive surgical margin, and age of the patient. This is the preoperative CAPRA, and the CAPRA S score. Pretty much putting the PSA, pathology, Gleason score, surgical margin, if it's positive or negative, and then overall, in both situations, we're going to have a grade for that. So grade, let's say over there, the first square over there that you see from 0 to 2, you have a 5-year biochemical risk, 3 to 5, and 6 to 10, and also in the postoperative score. And our main objective here is to show that now the importance now that of the markers, the genetic markers such as the GPS and the genetic tools that we have in prostate cancer, because only the clinical tools, they're good, but there still needs some further improvements, because now we know that the genetic value of the patient is very important as a prognosis, as a progression. So associating CAPRA score or all these clinical tools with the genetic profile will be a better tool to stratify the best patients. Talking about the GPS a little bit, very well known genomic assay that we have. And this is basically what we see here, right? What we see in the patient is a PSA, MRI, biopsy grade, and clinical stage, and etc. What the GPS talks a little bit about the tumor characteristics here: tumor biology, aggressiveness, recurrence risk, and all the hidden genomic information. So it's a complementary tool that we're using, and it goes from 0 to 100. The core of the GPS basically works with 17 genes. You can see here prostate-specific genes and reference genes, androgen cytolysis, cellular organization, stroma response, cellular proliferation, and then at the end you have the GPS result, and this is how we're going to use. This is the typical report of the GPS. You're gonna have the profile of the patient with the Gleason score, PSA, clinical stage, etc., prostate volume, and other parameters that we need to calculate the score. Once we have this score, we're gonna put the patient in low, moderate, or high likelihood. What likelihood of what? Of adverse pathology at a radical prostatectomy. Okay, so after that, we're going to tell the chances of having a high-grade disease, which is a Gleason 4 higher than 4+3, a non-organ confined disease. You can see the percentage here, 10-year metastasis, and prostate cancer death in 10 years. We presented previously our papers talking a little bit about the correlation of the GPS with the pathology. And after you have the GPS score, you can decide on active surveillance, definitive treatment, or informing the treatment intensity, etc. But now, not only the GPS, associating the GPS and the CAPRA score according to our paper, we could find a better tool to stratify. And this is exactly what we're doing. We're putting the CAPRA preoperative and postoperative score and showing a little bit of the molecular reality using the GPS score. Our study here, we got almost 1,000 patients, 955 patients with a median follow-up of 16 months. So we're a high volume center here in Celebration on prostate cancer and radical prostatectomy. We're doing around 1,200, now a little bit more cases. And we got a retrospective cohort. This is very important to say. This is one of the limitations of the article that I'm going to talk a little bit later. But it's a retrospective study of almost 1,000 patients that underwent a GPS with a nice follow-up, 5 years median follow-up. And our primary outcome was biochemical recurrence, so which is graded as a 0.2 in 2 consecutive measurements. And then it's a single surgeon with a dedicated uropathologist with a standardized approach. This is something that also it's a key point when you're evaluating such tests and such studies. Okay, so basically what we had a beta coefficient here, and we stratified this coefficients in preoperative and postoperative. And this is not a measurement that came from our head. This is involving a very complex statistic method. So we found, according to our cohort, our experience of almost 1,000 patients, that one CAPRA point was pretty much equivalent of 6 GPS points there when we did association between two. And when we're talking about postoperative scale, one CAPRA S point was pretty much equivalent of 10 GPS point. This is how we calculate it, just talking a little bit about the methods, and then you guys can take a look at the paper if you want to go deeper on that. So basically the CAPRA score plus GPS divided by 6, we're going to have a final score over here. And in the post-operative settings, a CAPRA score plus the GPS divided by 10, you have another trend over there. Also, you guys can go to the paper. And what we found here is, you can see the second bar over here. This is a C index. It's showing a performance of a predictive model. Okay, so if you take a look at the first example here, the CAPRA alone is showing us 0.67%, and the CAPRA plus the GPS, when we associated the CAPRA with the GPS, we could improve significantly over here from 0.67 to 0.76, so almost 10 points here. And a C index of 0.76 means that the model will identify which patient will recur before another patient in about 76% of the time. So that's what we have. In the post-operative is not that's significant compared to the preoperative. Also, it was statistically significant, but it's only added 0.003 from 0.81 to 0.84. But also in the postoperative, we can say that we had an improvement here. So basically, talking about these scores, a CAPRA-4, a CAPRA preoperative, plus a GPS of 26, we're gonna have a score from 0 to 8 at the end. Okay, so those are the patients that are favorable according to the grading that we're doing in our study. So CAPRA score, the GPS divided by 6, if it's in the range from 0 to 8, those are the favorable ones, and the CAPRA plus the GPS having a grade more than 9, those are the unfavorable. Okay, so this is according to our findings. In these two graphs, you can see, you can take a look at the CAPRA score and the CAPRA after using the GPS, the hazard ratio here, 1.54, and the second one, 1.31. You see the difference and also the statistic value of that. And also in this one, when you see the CAPRA post-operative CAPRA with the post-operative CAPRA associating with the GPS, you see that has a ratio from 172 to 1.58. You see the differences in the curves here. That's a very interesting. I'll suggest you guys to go there and to take a look. Okay, so the evolution of the prognosis here. We had a CAPRA, which is a great tool. CAPRA-S also a great tool, but we could improve the prediction of those models, those clinical models using the GPS score in the way that I just showed. Okay, so when we're talking about the clinical scenario here, those are real cases that I'm putting here. Those are real scenarios that I had. If you have the patient A here and the patient B, they're pretty similar, 62 versus 63, PSA very similar, grade group, clinical staging. Okay, both are CAPRA score 4. Both, if you put in a CAPRA score, they will be a CAPRA score 4. But once we associated with the GPS, we had some differences there. We had a GPS of 15, the other one 65. And if you do the calculations, this patient here with the same CAPRA score, they're gonna be in a worse prognosis compared to the first patient. The same happens with these two patients, almost pretty similar age, PSA, grade group, MRI here, positive course, and etc. When we put in the CAPRA model, both will have the same CAPRA score, but once we associate with the GPS, one patient had a GPS of 18, the other one a GPS of 52, and when you see the calculations, the second patient will have a worse prognosis. So this is showing that the clinical tools that we have, they're great. They're doing a much better job than the previous years that we didn't have them, but now associating with the GPS profile and all those genetic profiles, we're going to have a much better association. When we have those two patients, two young patients considering focal therapy and etc., and we have two patients with the similar age, similar PSA, grade group, clinical staging. Once we put in a CAPRA score, again, they're going to have similar CAPRA score. However, when we see the genomic profile, we're going to have one having a GPS of 22 and the other one in 34. So perhaps it's not established because this is only a suggestion that we give in the paper over there. This is not established, not even guidelines. You need a external validation also. But this is something that we discussed in the article. Perhaps the guy that we think that are great candidate for the focal therapy, they're not due to the genetic profiles. They have better chances of having a more aggressive genetic profile over there. When talking about after radical prostatectomy here, two patients, that underwent radical prostatectomy. We have all the patterns here, which is extraprostatic extension, margins, and etc. Capra postoperative, Capra S of 3. And when we associate with the GPS score, we see that the second patient is a patient that we're going to need a closer look. We're going to need to pay more attention at this patient. And also, it's important to counsel, telling that genetically he had a more aggressive cancer. So we need to have this closer follow up with the patient. So the main question I already answered during the slides is why adding the genomics in there, right? The clinical dilemma. So I showed a lot of different cases, okay, that associating the genomic with the CAPRA score, we're gonna have a different plan on this patient, a different stratification and a different counseling, or even a different strategy of this patient when talking about the focal or surgery and etc. And limitations, it's important to talk a little bit about the limitation of the study. This is a single center study. This is our experience, as I said in the previous slides, is something that we did here. This is a retrospective study with 1,000 patients, single surgeon center. It's very, very important to do external validation. So if you guys are planning to do some further studies, we're glad to collaborate as well. But I think it's important to have more literature talking about external validation and replying and doing the replication of this study in other centers. We know now the path forward that the genetics, associating everything in genetics will be the way to go, not only prostate cancer, but bladders, kidneys, and other types of cancer. And we should always say that one size doesn't fit all. I showed a lot of different examples over there of patients that look like similar, but the genetic profile of the patient can tell us something more than most likely going to benefit during the treatment, during the follow-up, and during the plans for these patients. And thank you very much for the opportunity. I'm going to open and now for the panelists and for discussions and further questions. Thank you very much. But before we start, I just want to introduce both panelists here. They are very well known, but I just want to introduce Andrew Weiner. He's Chief of Urology in NYH Health, plus Hospital Kings County and Associate Professor, Program Director of Urology Residency, Clinical Advisory Dean for Medical Students in SUNI, Downstate and Director of Robotic Surgery in Kings County. And James Kearns, Jamie, is a board certified urology graduate in Columbia University, Vagelos College of Physicians and Surgeons, and he's a high volume surgeon in prostates and prostate cancer, BPH, and all those surgeries. So let's start a little bit. Let's start, Andrew and Jamie. What do you guys have to discuss here? If you guys have anything to share about your practice and what you saw in the slides. I have a few questions already, but I just want to open for you guys to introduce a little bit to us as well.
First of all, congratulations. I think this is a really nice manuscript paper showing what a lot of us are seeing in our day-to-day clinical practice. We have so many patients with very similar favorable intermediate type of risk profiles. I think that's the gray zone in prostate cancer decision making these days. And to really rigorously take a look at your data and see how genomic analyses can impact and really give us more data to sink our teeth in with our patients, it is really exciting to see. And it really falls in line with a lot of what we're seeing in our clinical practice and is encouraging going forward.
Andrew?
Yeah, I mean, I couldn't agree more. I think that to put some data to, what we're seeing clinically is really valuable. I love using genomic biomarkers and I get, some feedback that not everybody does. And, the reality is what we're facing these days is like a puzzle, and we're trying to put together the pieces and figure out what's ultimately best for patients. And we know that age and PSA and grade group and T stage MRI, they're all very, very important variables that we take into consideration, but they're puzzle pieces. And they don't tell us anything about the behavior or the biology of that
Yeah.
patient's disease. And you guys showed this really nicely that you can take these clinical factors, but that the biology actually adds significant value. And so for me, these genomic classifiers like GPS, they don't replace the clinical pathologic variables, but they help us unmask, I think, potentially aggressive biology. And so, if I were to say where I find the greatest need or value in these tests, it's really to be able to transform this uncertain moment where you're sitting together with a patient and their family, and you say, well, I'm pretty sure it's this because my pathologist called it that, but you can actually personalize a discussion of risk for that individual and ultimately allow them to make an educated decision based on how they want to proceed.
Yeah, I totally agree. And I think now with those genomic profiles, we're having some questions that we used to have like 10 years ago when you see like two patients in clinic, you say this patient went so good in the post-op, in the follow-up, in the PSA recurrence, and this patient was so bad, and they were so similar. I think now the genomic profiles, they're giving us more tools and understanding why this is happening. I think that's a great point here.
I just want
And
to make one more comment about that. So, to your point, Marcio, not every GG1 is the same. And you mentioned this in your
yeah.
prelude here. Dan Lin, Neil Patel published in 2025 this beautiful paper, in JAMA, I think, that showed that you can actually stratify GG1 alone into low,
Mhm.
intermediate, unfavorable intermediate, and high risk disease. And we're all seeing this. Jamie, I know you're seeing this. You can see explosive GG1. And what I want to know is what's happening under the hood. And that's where these tests really shine.
Exactly.
No, I couldn't agree more. And that the GG one is interesting. I mean, it's so almost dogmatic at this point that people want to say it's GG1. Do we even call it cancer?
Yeah.
Ignore it, go away. And I think that for most patients, sure, we should be watching it and keeping an eye. But you think of these guys with the strong family histories, the high volume disease, the PSA that's out of concordance, and you're like, look, I just need to continue to convince you that this is real. And I think that this helps with that overall picture. I mean, it's like a Polaroid picture. How much more can you add in to clarify what's coming in and bring it into focus?
Yeah, and that's a great point. And I think something that I tell all of my fellows and the students that those now the genomic profiles, the genomic tests, they made the scientific community think a little bit better about the GG1 because we had a trend 5, 6 years ago in some conferences. No, this is not even cancer, guys. Don't worry about it, and etc. And we, as a high volume centers, we were seeing several of those patients having recurrence, having problems, having metastasis, and nobody could explain why, right?
And that's
Now,
with
now,
that's with a trained geopathologist. I've heard
yeah,
people say, "Oh, it's because you don't have a trained geopathologist. You have an excellent
yeah,
pathologist,
yeah,
I'm sure."
exactly.
So it's
Yeah.
not that, it's the biology of the disease that's discordant.
Yeah, and I think this is the first take-home message that we have here. Never underestimate the tumors you have, the profiles you have, unless you have all those genomic identities to tell us a little bit more. Of course, the vast majority of the GG1s, they won't give us problems, but some of them, when they do, they we've seen some patients with some bad diseases after. And for both of you, just a few questions that we have here from the audience. And in our practice, where do we find the greatest incremental value for GPS beyond the traditional clinical value? So, guys, basically, where do you guys use, or who are the patients that you look and say, this is the guy that I need a GPS, or this is something that we need to look a little bit further? or you do for everybody? How do you guys do in your practice?
Jamie, you want to take
Yeah, sure. I mean, honestly, I can think of two from today. Just
it?
in clinic, my clinic this morning. It's my favorite thing of the week, right? But I had one guy this morning who was grade group one, PSA though of 19.5, big prostate. It was 90, 100 grams, and but low volume grade group one, T1C. We do a lot of prostate health index here as our secondary serum biomarker, and that was also favorable. It was in the lower risk, like 43, which for PHI is pretty low. And we see these patients I see these patients a few times a year where we see these really high PSA values. It's uncomfortable to watch him. His GPS is 13. And it was a really interesting conversation because I said, look, I don't like your PSA, but everything else here looks really good. Your GPS is excellent. I was actually referencing your data in the office. I brought up some of the prompt data as well. I think not for tonight, but I think that's also compelling in this conversation. And was basically like, look, I don't like your PSA, but everything else is telling me this is low risk. And we made the decision that we're going to keep an eye on it. We're going to do another biopsy in 6 months. And, biologically, based on everything we can see, this tumor is very unlikely to do anything really aggressive. Similarly, toward the end of the day, I saw another patient who was, by all accounts, favorable intermediate, low volume 3+4, a couple cores of 3+3, one of pattern 4. I think it was 15-20% pattern 4 distribution, but his GPS came back at, I think it was 38. And so again, you add that picture in and you can say, well, this really influences the picture, and we're setting him up for surgery. And I think without the GPS, this is somebody who probably would have ended up watching his cancer. We would have done some biopsies in the future, but this is less comfortable to watch it. And given those advances in information in the tumor biology, seeing what you're showing right here with this information, that plays very much into he's probably more unfavorable to intermediate and benefits from treatment. I mean,
It's
Andrew,
funny.
where's your
It's funny
experience?
because I have the same exact patients, and from within the last 2 to 3 weeks, I would say the sweet spot, if you were to ask me for this test, is high volume, more than 4 cores of GG1, or low volume favorable intermediate risk disease, less than 2 cores of grade group 2, with less than 15 to 20% of pattern 4. Exactly what you mentioned, Jamie. Um, for these, I think that you have this tool in your toolbox that is covered by insurance
Yeah.
and it's readily available. And for me, I can't understand why you wouldn't add that to be able to have the conversation with the patient to allow them to ultimately decide. People ask me all the time, what's your cutoff for intervening? And you mentioned a GPS of 38. Well, I use, 30 as my cutoff for reassuring versus non-reassuring. And I don't say treatment versus not treatment because it's a conversation. This whole thing is a conversation about their disease and risk and what they're able to tolerate. And then ultimately they decide. And I think that that's where this test really shines is in the higher volume grade group 1 and the low volume grade group 2s.
Great, guys. Yeah, I have the same sensation in all of you guys. And the more we use, the more we understand about it, and the more we see the benefits, right? And as you said, Andrew, as soon as it's covered now by insurance and everything, I mean, this is something that I strongly believe that there's no way of coming back, right, to our previous practice without the genomic profiles.
And I
So,
think to
and
dovetail a little bit into that coverage and economic standpoint, I mean, I know you guys talked about the cost in the paper. In our current world of patient-centered medicine, and I think it's really important that we're looking at the patients at the center of this, the out-of-pocket is nowhere near the published price. And I think we need to keep that in mind as well. Most patients
yeah,
are paying quite a bit less, even when they don't have full insurance coverage, but the ceiling on the test is under $300. And
yeah,
while that's a different amount of money to every single patient, I would never presume to say that that's insignificant or significant to any given patient. I do think we need to keep that in mind of, when we're talking about healthcare costs, yes, there's the abstract, what does this cost the system? But
Mm.
very concretely, we know that we're not costing our patient an inordinate amount of money out of pocket with these tests as well. And that I think plays into it significantly too.
And Jamie, for me, when you talk about healthcare costs to the system, you can actually make a very significant argument, and they actually have a few papers within the company and published in the medical literature showing that these tests save money in the long run.
Yeah.
Because I use my GPS results to help tailor my active surveillance strategy. So if you have a low risk patient and a very low GPS, I'm holding off on restaging biopsy for indefinitely, actually. If there's no MRI lesion and there's no reason to be concerned about any PSA bumps, I'm watching that patient. So if I can save the healthcare system, MRI, biopsy dollars, we're actually saving money in the long run.
No, agree 100%. And very similarly, I mean, that's still somewhat an unanswered question, but if that negative predictive value is so high and we can save patients the cost and the inconvenience and the risk, that's a win for everyone involved.
Yeah, no, I strongly agree. We put in the paper, if you guys take a look, we put this financial discussion more because here in the US we have a different reality, right? We have like covered and everything. Some places they don't have too much access. But as you said, it's already well established in the literature with some papers telling that how much we can save money using those tests to avoid further treatments, further tests, further exams. So we definitely have advantages over there. And I know that you guys are using a lot, but one of the questions we have here is that is there any point that you guys don't use or you feel comfortable? What kind of patients you feel comfortable or not of not using it, or you use for all your patients? How do you usually apply that to your clinical practice? How do you guys usually tackle this part of the in your clinic?
Andrew, why don't you take this one first? I
Yeah, I
think.
mean, I would say that if you have grade group 1 and 5% of one core and very modest PSA, somewhere between 4 and 10, I don't think you necessarily need a genomic classifier to tell you that that's low risk. And so that's a patient that you could very comfortably say, we're just going to repeat the PSA and go down our active surveillance protocol. Um, but for multiple cores, for me, again, I think that this is equally, if not more important than the MRI. I think the MRI helps target our biopsy, but I can't tell you how many PIRADS 4s have come back as grade group 1.
Yeah.
And I'm left scratching my head wondering, is this real? Is this not? And it's the biological piece, the genomic component, that really can answer that question. So I would say that aside from a very, very low risk, again, tiny little core, that's probably going to be insufficient for analysis. I'm gonna get a GPS.
Yeah, I totally agree on those really low risk patients. And I would say on the converse side, if somebody has a set of clinical factors between higher grade group, higher PSA, higher disease volume, that I'm going to recommend treatment one way or another, I don't know that I need to get a GPS in those patients as well. I mean, somebody's got a Gleason 8, 9, 10 prostate cancer, we're going to treat it. And so adding that additional test at this point in the treatment probably is not going to be a significant add for those patients either. So it's either
Guys,
really low risk or really high risk.
I agree, and I'll put a scenario here. I didn't put in my lecture, but this is something that happens to us, and it's very usual, to be honest, very common to us. We receive patients from all over the state and even some other countries here in our center. And the biopsies done outside, they're not as accurate as the ones done in our center, of course, because you guys also as a high volume centers and high volume surgeons, you know that your pathologists, basically trust what he or she is doing because of so many biopsies that they seen. But in the community, it's not like this. So we sometimes change a lot our plans when we receive these patients with a biopsy. And for instance, you get a GPS that is sky high. A guy has one core of those biopsies that are like 6 cores, those not standard biopsies. So one core, Gleason 6, and say, no, how come this is a Gleason 6? This genetic profile here is kind of sky high. So in some of these cases, those are key and or red lights to us to do a new biopsy based on the genetic profile. I don't know how you guys deal with that. I believe you guys also have similar situations, but this is something that happens with us kind of usually.
Yeah, for sure that can happen. I think it also saves the patient another biopsy, right? You can run this test and it's going to take the index lesion, which you're concerned about, and run an analysis. But to Jamie's point, I think if I have a grade group 3 patient who's a few comorbidities, I'm going to take him to surgery. I don't necessarily need additional testing on that. But if I'm up in the air about treatment versus active surveillance, or even intensification or de-intensification of ADT for my unfavorable and high risk patients who are going to undergo radiation, I'll run a genomic biomarker. So GPS can help clarify that scenario as well.
And I'm also increasingly in these, grade group 1 patients, really tailoring my active surveillance strategies, not just avoiding the biopsy completely, but let's take the patient with 3 cores of grade group 1, probably 30-40%, PSA of 7, they're in their 50s. By our institutional active surveillance protocol, once they get through their first 2 biopsies, we're doing them every 2 years across
Yeah.
the board. But when you add in the GPS, if that patient's got a GPS in the 20s or maybe even low 30s, I'm not going to wait 2 years. I'm going to be doing that sooner in those patients. And whether they came from outside or inside, that's another place where it really tailors the protocol, short of necessarily taking them to treatment, but can still have a significant impact on their care.
Oh yeah, absolutely. Could not agree more. I would even urge you to go so far as to push your institutional protocol on the opposite end, which is that to de-escalate some of this surveillance based on the genomic profile. I put so much stock in this that I think in combination with Path, with genomics and all the other clinical features, I think you could make the argument to de-escalate that protocol.
Yes,
No,
and this is what it was exactly what I was going to enter. The opposite also is as you just said, the opposite is also like you're doing the Brio protocol every 2 years, a new biopsy. You have a low profile, low genomic profile over there. You can wait a little bit more. You can counsel the patients because the genomic component of the tumor most likely won't be aggressive. That you're gonna need to do a biopsy every 2 or even 3 years.
and I want to plug Dan Lin here because we invoked him. Dan Lin was my fellowship director and one of my key mentors in fellowship. And one of the things we published was the implication of negative biopsies on active surveillance and how if you don't see cancer on a subsequent biopsy, that your likelihood of upgraded and need for treatment down the road is exceptionally low. I would extrapolate that to say if your tumor biology is demonstrated through one of these genomic tests is incredibly low as well, then perhaps those patients also don't need additional biopsies until we have some other signal, whether it be, a serum biomarker, whether it be an MRI. I'm going to throw exo out there, whether that changes, and see if any of those things make us decide to do a biopsy in the future.
Perfect. And how you guys usually counsel your patients? For instance, you have your patient in your clinic, and then you're gonna order a GPS test or any genomic test over there. How do you guys counsel for doing the test? This is the first question that we have here, and then after having the results, how are you gonna say this by this patient? Well, let's say it's a high GPS over there score. Do you have a genetic counselor to talk to them, or you do it by yourself, or you do both? I'll wait for you guys, and then I'll talk how we're doing in our center. But there's some curiosity that people put over here.
Yeah, I mean, I do think of genomics and genetics very separately for our patients.
Mm-hmm.
I mean, the number of patients with the, RPMs, the rare pathogenic mutations, are going to be pretty uncommon, especially in the low risk and even intermediate risk patient population. And for those patients, we have a robust genetics program. We get them into our genetic counselors. We'll look at polygenic risk scores and things along those lines. But I think with the genomics, I'm not necessarily getting them plugged in with those extra ancillary services, but more using that as one of those many multi-parametric factors in helping to talk about their specific cancers.
Yeah, I agree with that. I mean, our genetic counselor is in such high demand from all of the different services that first of all, I think it would overwhelm them. And second of all, I don't think that that's their realm, to be honest. I think that these genomic classifiers help us make decisions as urologic oncologists or urologists because, all of us are taking care of prostate cancer. I actually would say that the low and favorable intermediate risk space is one of the hardest conversations and negotiations that we have in urology. If you have high risk disease, well, it's a hard conversation because, they have aggressive disease, but we know what the treatment strategy is going to be. For this one, it's, the number of options that are out there are plenty, and there's a ton of decisional regret and psychological burden that takes place with all this testing, plus the diagnosis of cancer. So I think we're stuck in this situation where we have to really understand what we're dealing with before we make our recommendation, and that's where this really comes into play. And the way I explain it to them is, that exactly how Marcio in the video that you put forth, how I explain it is basically two men can have cancers that look identical under the microscope. But, one tumor is biologically quiet and the other one can be more aggressive. So, in other words, genomic tests tell us how a cancer behaves. And, genetic testing is more the inherited risk. And I think that's somewhat of a misconception for a number of my patients, at least.
Yeah, and I like to explain to patients a lot of times cancer is you outliving your mutations. And so cancer is obviously a disease of somatic mutations for us when we're talking with patients, but I tell patients it's outliving your mutations, and different mutations that have different levels of aggressiveness can look the same under the microscope. And this helps us get at the underlying biology and the underlying set of mutations and how those might influence the risk independent of what we're seeing under the microscope.
Perfect. I agree again with you guys, but I'm very particular in talking to the patients about it because my experience, I see the patients they're very excited and with a big anxiety also when they have those tests and telling, oh yeah, my GPS was 39. And they don't know basically what is that. So I think it's very important to us to sit down together. I usually try to print the whole thing and show them. So this is the prediction. That's what I told in the video. This is the prediction of metastasis. Not that you're gonna have the metastasis, but based on a cohort and a study, I don't know, 10% of those patients had metastasis. So that's basically what you have now. And also, I strongly believe that usually the wives of the patients, they're more they have more questions and they're more concerned about those tests. So I usually try to put both together. So the take-home message here is to explain well, sit down, because this can produce a high level of anxiety in the patients. We have patients that are calling all the time. Yeah, I have my GPS ready, but nobody's telling me what's, you know what I mean? And so I think just sitting down and explaining what we need here. We have another question here. If the patient elects surgery, does GPS change the surgery protocol? I'm gonna have my answers here, but I'll wait for you guys because what I will tell is based on a previous paper that we did with GPS comparing with the final pathology. But what do you guys think? The GPS will change the surgery protocol or the way you do it? How do you guys tackle that?
So there's actually, I love the study that you guys put together in your group, Marcio, about every quartile that you increase, it increases your risk of extraprostatic extension,
Mhm.
seminal vesical invasion, and positive surgical margins. And I quote it all the time. But I would say that still, for me, the gold standard for surgical planning is the MRI. And
Mhm.
so that's really helpful, the two in conjunction. But I will say there was a study out of UCLA that looked at multiple variables, including MRI, grade group, PSA, and the GPS score. And the only two that stayed in the model were grade group and the GPS score. So in a multivariate model, only GPS and grade group were significant for, basically adverse pathology at the time of prostatectomy. So for me, the MRI is important. There's been many studies that show that for surgical planning, it's important. And GPS is one of those factors that will also help me decide. But I wouldn't say I'm going to, nerve spare on a side or not side
Yeah.
based on the GPS score.
I'm actually gonna be a little more provocative here. I think virtually every patient you take for robotic prostatectomy is a candidate for nerve sparing until they're not. And so I can see a patient that I'm concerned about seminal vesicle invasion. I'm concerned about broad prostatic abutment of the capsule, what have you. And I absolutely am taking that into account. And I think GPS is in line with those clinical factors of saying, hey, these are more aggressive diseases. And if I have any issues, stickiness, what have you in the OR, I'm going to bias toward getting outside a lot quicker. But I think that I give most of my patients the benefit of the doubt in terms of if those planes are coming off the prostate nicely, I think you can take them, and I think you can very reasonably be comfortable with that. But higher GPS, MRI, what have you, I'm not going to be hugging the capsule quite as closely. I'm certainly not going to be risking a capsular incision in the same way I might with somebody with a lower risk profile.
Yeah, I totally agree, Andrew. Our in our center and my practice as well. All patients undergo MRIs to do the prostatectomy. I think that's the best exam to do anatomy study and everything. And I don't, in some, we did this study with 720 something patients, and we divided by a quarter. And then basically, we kind of discovered there that GPS more than 29, the patient had a higher chances of extraprostatic extension as well. But as you said as well, I don't change my approach there based on those values. Like, oh yeah, a GPS of 30 or 35. But I know that on that side, most likely I'm gonna have something else extra. I have a higher chance. So I go with more cautious. I won't change because I also like to do nerve sparing in all patients, unless you go in there and you see that it's very stuck, even in Gleason 9s, oh, very stuck, and then you go outside of the prostate and take the whole thing out. But I won't change that much based on the value, like 29, 30, 35, etc. But I'll be more cautious. That's the only thing that I would do if these patients they have the GPS doing. Okay, we have a poll here. GPS plus CAPRA poll. 65-year-old patient, CAPRA low risk, GPS returns higher than expected genomic risk. What is your management inclination? Active surveillance, definitive therapy, treatment intensification, and other. Um, okay, let's go on this one. We will wait a little bit, and then I'm gonna read the second one, and then we can see what's happening there. In your practice, what is the biggest challenge to overcome? Patient understanding, workflow, reimbursement, interpreting discordant results, and other. So wait like 2 minutes let's say like this. I think 2 minutes too much, right? People, it's like two questions. 1 minute per question is too much here, okay?
We'll end the result. Get you guys some responses.
Uh,
All right, let's see responses. All right, so it looks like on that first question, 65-year-old patient, about a third of the respondents chose definitive therapy, 22% chose treatment intensification, and 44% chose other. Let's talk. What would you guys do in that situation? 65 years old, low risk CAPRA, higher than expected genomics.
I'm so excited right now. I love this. This whole poll thing is so cool. Um, and this is real life patient. I mean, I can't tell you how many of these I see. So, I'm envisioning a 65-year-old, relatively healthy person who's got, 5 cores of grade group one, and then his GPS comes back. Let's say it's 35. Okay, because if you take the extreme, like 55,
yeah.
that's no question they're going for definitive therapy. But I would make the argument that at 65, even with a GPS of 32 to 35, I think that patient is still an active surveillance candidate. But I'm going to tailor my active surveillance strategy and bump up that restaging biopsy much sooner. So I'm going to do it at 6 months rather than at 1 year or 18 months. So I'm not going to do another MRI. I'm just going to go straight for, I'll probably get a PSA at 3 months. And then, if that PSA is rising significantly, then maybe we'll pull the trigger. But if the PSA is reasonable, then I'll rebiopsy him at 6 months.
No, I think that's great. I had a slightly different but still low risk patient in my head. So I was going to go with a 62-year-old, so early 60s, grade group two. So that's their 2 points to keep them in low risk CAPRA. So PSA less than six, T1C patient, low volume, whose GPS comes back at, say, 35, which would definitely kick them up in the CAPRA score. And I agree with you completely. I would not necessarily push that patient for surgery at this point, but I would do our next biopsy at 6 months, or let's say this is on the confirmatory biopsy, and I would normally wait a couple of years. This is a patient in whom I'd bring back in a year rather than 2 years to do a repeat biopsy. But I don't necessarily think I'd recommend taking him to surgery at this point.
Okay. So,
But what about you, Marcio?
Yeah.
oh, my opinion. Okay. Uh, First, I will put both decisions on the table, right? Usually those younger guys, let's say younger 62 to 65, they're not the candidates that want to operate, but depending, some guys are very particular with that, with cancer and etc. I totally agree. I would do a biopsy within 6 months to 1 year, not more than that, not passing 1 year, but I would offer the treatment. I would tell him, look, this is what we have, your profile, your genetic profile is not uh, as good as your CAPRA score or your GG1 there, but you have a chance over there to have a surgery, and then I will share the decision according to what they want to do. But definitely, if I will keep them in active surveillance, I will do a biopsy within 6 to 1 year, not more than that.
Yeah, those are great perspectives. And then this one, we've only got a couple minutes left, so speed round of answers on this last one. In your practice, what's the biggest challenge to overcome? 33% said patient understanding, 33% said interpreting discordant results, which is great with the topic of this presentation today. Workflow at 11% and reimbursement at 22%. What's your guys' take? What's the single biggest challenge to overcome in your practice? Lightning round.
You can take it, Jamie.
I'm going with discordant results. I think workflow and reimbursement we figured out really well in our practice, and patient understanding. That's why we set up these long appointments to sit down face to face with patients and their wives. I say married men live longer all the time for a reason, and that's on us to really talk to those patients. But I think the interpreting discordant results is probably the biggest challenge I face.
I think that interpreting discordant results is challenging, but it's actually the equivocal results for me. So I would put other in that category. I would click other on this poll. The ones that live at 28, a GPS of 28 and have high volume grade group 1 or low volume grade group 2. 28, 29, 30, like hover right in that median of the bell curve. That can be a little bit confusing to discuss with patients and kind of prohibits me from making a strong recommendation.
Yeah, yeah, I think that's important. We still have an area there around the 20s that we have sometimes even us with some questions there, we intensify or not. But to me, I think patient understanding in terms of doing the treatment or not. Some of the patients they go straight with the guidelines, telling, for instance, GG1 with a high GPS there, you're telling them, look, it would be better if you operate, if you do any, if you do a treatment there. But they get this information of the GG1, yeah, but Gleason grade 1, I'm active surveillance candidate. So sometimes they come with this information from ChatGPT, from something extra there, and we have the genomic thing that they don't understand yet. So we kind of need to discuss, okay, we understand, however, now you have a complementary data from your genomic profile that perhaps you're not a good candidate over there. There's not too many studies outside, so that conversation to me sometimes it can take a little bit more time there.
Great perspectives, everybody. Thank you. Okay, we have one question that came in from the chat. We'll do it as a quick yes or no answer. I'm sure we could get into a great discussion as well on this, but final one, and then we'll close for the evening. Are you guys getting GPS on the original path and confirmatory biopsy, or just the original pathology? We can do a yes or no on this one. Original and confirmatory, or just original? Great.
Original and confirmatory. I do serial GPS because I find that the biology changes.
Oh, Dr.
Jamie,
Kearns,
you're on mute.
Sorry about that. If they go from grade group 1 to grade group 2, I get it on both. If they stick at grade group 1, I use the original path alone.
Dr.
Yeah,
Moscova.
yeah, that's also my I would go with Jimmy. Also, if we have a changing over there, something different than the first one, I would go for a confirmatory.
Okay. Wonderful. Well, we are at time this evening. I would like to extend my gratitude to our panelists. Dr. Moscovas, thank you for moderating today. Dr. Kearns and Dr. Weiner, thank you for participating. Absolutely enjoyed the discussion this evening. I think you offered some really great and unique perspectives. And I love that you all apply everything slightly different. It's great to see the differences. I'd also like to thank our audience for joining us this evening. If you have any questions, please feel free to reach out to marketing@mdxhealth.com. Otherwise, I hope everyone has a fantastic rest of your week and have a great night.
Thank you very
Thanks,
much. Thank
everybody.
you, Jamie. Thank you, Andrew. See you guys on the next one.
Thank you,
Thanks
everybody.
for
Have a
having
great night.
us.
Thank
All
you.
right. Good evening.
Take care.